Okay. So I realize this presentation is a lot longer than what we usually give, and this is a lot of review type concepts for you guys. What I'll try to do is try to tie in some of the pathophys with the pharmacology, so you're kind of reviewing the pathophys and then learning the pharm at the same time. All right? Okay. So this is the continuum. Acute coronary syndromes and coronary artery disease or coronary heart disease, they all have the same meaning. But essentially what we're talking about is myocardial infarct, right? So the patient has a heart attack. And so we're going to go through the drug classes that are required to treat this continuation. I don't know why all these are animated. One of the main therapeutic strategies for several of the drug classes that we're going to be talking about is going to be centered around reducing oxygen demand. So remember, the heart's a muscle, okay? And so in order for it to function, it requires, obviously, oxygen-rich blood. And that oxygen-rich blood is coming from the coronary artery. And so this oxygen-rich blood branches off the aorta, and then it recirculates back to the coronary circuitry to basically perfuse the heart in oxygen-rich blood. So it takes a little bit of the oxygen-rich blood it's just about to send through the systemic circuit to feed itself, okay? And so a heart attack is essentially a disruption of that blood flow. Okay, and so when this disruption occurs, you get localized ischemia, all right, and then that leads to cell death, and it leads to a loss of function of the myocardium. Okay, so just some kind of housekeeping. Coronary heart disease, or sometimes called coronary artery disease, CHD or CAD, is a narrowing of the small blood vessels that supply the heart, the coronary artery, and that leads to this syndrome called the acute coronary syndrome. So it's a situation where blood supply to the heart is suddenly stopped. And when it's abruptly stopped and it leads to ischemic myocardial cell death, we call it a heart attack. Okay, and so the way we test whether or not a heart attack has occurred is looking at the EKG. All right, and so where that ST segment lies relative to the isoelectric line is going to be one of the first kind of diagnostic criteria in terms of, did the patient have a heart attack? Okay. A lot of the processes that are involved in a narrowing of the coronary artery are immune-based and endothelial-based. And so if you look at this concept of the progression of atherosclerosis, and I love this diagram because this puts basically all of our drug classes and all of our pathophysiologic processes on one slide. But you can see one of the early contributing factors is free LDL, okay, followed by endothelial cell activation, okay, and so this is an upregulation of certain integrins, certain cytokines, certain chemokines that are pro-inflammatory. This aids in monocyte recruitment, okay. When monocytes get recruited through the endothelium and come into contact with oxidized or free LDL, that leads to the formation of a special type of macrophage called the foam cell. This leads to further inflammation, and you can see as this process occurs, the vessels get more and more narrow. And the outcome of all this pro-inflammation is really the formation of a thrombus or a clot, okay? And so this actually kind of justifies three of our drug classes, okay? The statins, okay, as well as some of the antiplatelet type agents, and there are several that we can use here. And then we'll talk about targeting the thrombus in the latter part of this lecture, looking at anticoagulation type drugs for the treatment of myocardial infarcts. All right? And so you guys should be aware of the clinical presentations. I'm gonna move angina or angina to tomorrow's lecture, I think. I think it makes more sense to talk about it in the context of myocardial infarcts, and then I think what we'll do is we'll put the side effect lecture, I think we'll do next week, after we've had kind of an opportunity to talk about all these drugs at some point. So angina, or angina, if you're from the south side like me, is associated with a shortness of breath, profuse diaphoresis or sweating, this notion of feeling nauseous and vomiting. That vomiting and nausea, where do you think that comes from? What neurotransmitter is driving that? Okay, in the progression of a heart attack, there's an abrupt disruption of blood flow, and that causes chest pain. That's lactic acid in the myocardium, okay, and that's what the pain of angina is coming from. The nausea and vomiting is really the activation of the vagus nerve, okay, releasing all this acetylcholine, and that's actually the thing that's kind of driving the nausea and the vomiting. And the activation of the vagus nerve is the compensatory response to elevated neuroendocrine type neurotransmitter release, and so norepinephrine and epinephrine. The pain or discomfort could be from the lactic acid permeating through the different circuits. It could also just be the lack of blood flow in these particular regions as well. And so we'll talk about angina as a separate entity tomorrow. What we're going to do is we're going to start from angina today, and the reason I have to put this lecture first is because it's longer. We had more time to do it today. But understand that today's lecture and tomorrow's lecture are occurring simultaneously in the disease process of the patient. So the angina is the thing that brings them to the hospital. Now we're saying we're having a diagnosis of a myocardial infarct, and we're going to treat them. And so how did we get that diagnosis? Well, we looked at a 12-lead EKG. If the patient comes in and says they have chest pain, you got to get them hooked up to the EKG machine within about 10 or 15 minutes. And we're going to look for key, specific findings. We're going to spend a lot of time looking at the EKG and interpreting what this looks like. If you reference the ST segment, and here's the ST segment by this arrow, if it's elevated, if it's above the isoelectric line, that's a real good indication that the patient is having a heart attack. And that's one of the definitive diagnoses. So for today's lecture, we're really going to kind of focus here on STEMI, ST segment elevated, myocardial infarct. Okay? We'll talk about some of these non-ST segment elevations a little bit later during the pathophys component. Okay? So a patient walks in, they say they have chest pain, you hook them up to the EKG. Their EKG shows or demonstrates an ST segment that's well elevated above the isoelectric line. And the first thing you have to do is initiate reperfusion therapy. Okay, so this is basically going in there for the through the femoral artery and going through the circuitry, going into the right coronary artery, and then removing the clot that's causing this lack of perfusion. Okay, and of course, in the pathophys component, you talked about, or you will talk about the cardiac enzymes. So we have that lecture already. I'm behind. I just got in yesterday from a conference, and then we're going to be starting talking about pharmacology. And so at this point, it's pretty well indicated that the patient had a heart attack. Okay, we'll talk about these ST segment depression, T wave inversions, and then normal EKG changes later. But essentially, they didn't have a heart attack. We're going to monitor them because obviously there is some type of maybe abnormalities in coronary blood flow. These are the patients you'd risk stratify. You'd kind of keep a close eye on them. Maybe you wouldn't admit them, but you'd definitely schedule a stress test in the next 2 days or so. But these particular patients in this black box would be the ones that you wouldn't necessarily worry about dropping dead in the next 30 minutes or so. Okay, so these were where you'd implement like lifestyle changes, risk assessment, maybe looking to see if they have a underlying hypertension or underlying arrhythmia that hasn't been diagnosed. But that'd be kind of this patient pool. Okay, so the ST segment is really important. We're going to say that for this lecture, these patients are coming in, they've got ST segment elevated, they've had an abrupt cessation of blood flow to the heart, to the myocardium, and that's the thing that's inducing myocardial cell death. Of course, we'll confirm it from a biochemistry standpoint, and I know you've got a lecture somewhere on cardiac enzymes. This is for review. Typically, we're looking at troponin and CKMB levels, and we know that they peak. And so you get early on, you get an increase or an influx of these two biomolecules being produced, and there are certain thresholds at different hospitals and centers. But if you're in the 50s and 60s, that's way over the minimum cutoff, and that's where you get a positive diagnosis of myocardial infarct based on troponin, or a positive diagnosis based on CKMB. A lot of hospitals will do both, just to be extra cautious. And of course, over time, and this is days after infarct, those levels return back to normal. So you've got to get this. It's really important when the patient walks in complaining of chest pain to get these serial measurements, because you want to see this elevation in these two enzymes along with that ST segment elevated abnormality that you see on the EKG. Okay? And so one of the contributing factors to coronary artery disease is the etiology of atherosclerosis. And so here's this pro-inflammatory event that's in the vessels. And that leads to unstable plaques. These plaques may rupture, and they may occlude vessels, specifically vessels feeding the heart. And this is caused by our crappy Western diet, patients having high LDL and very low HDL readings, persistent endothelial damage from reduction or restriction in blood flow, okay, and a few others. And so, when we talk about some of the causes of coronary artery disease, this is really nice because this actually kind of breaks it down for you in terms of the disease or the syndrome or the process and the things that produced it. So atherosclerosis is probably the number one reason, of course, and you get, this is underlying hypertension that may or may not be adequately treated, excess cholesterol, diabetes, of course, a history of smoking, and a family history of atherosclerosis. And so, these patients have, extra thick blood, they're hemodynamically unstable, and this is one of the contributing factors to myocardial infarct and stroke in this country. Coronary artery vasospasm can occur. These are mediated by a lot of, my computer just went black. But it's there. The screen just went black. No, now it's back. Now we're good. It's weird. It just went completely black on here, but then it was fine there. Coronary artery vasospasm, we'll talk about. This is kind of a unique event. Essentially, it is what it sounds like. It's the coronary artery constricts. It's really prevalent in the Japanese population. We don't see a whole lot of it in this hemisphere, but it does occur. It's mediated by some of these neurotransmitters that are listed here. Emboli, another kind of a rare cause in coronary artery disease. When we talk about embolisms, we usually consider deep knee thromboses that move and migrate from the vasculature in the lower leg into the lung or the pulmonary circuit. And of course, the most rarest form of coronary artery disease that leads to myocardial infarct are these congenital deformities or abnormalities in the coronary artery, which is actually me. I'm not only speaking to you as a pharmacologist today, I'm also speaking to you as a patient. I had a heart attack when I was 30, and so the reason was because of this congenital abnormality in the coronary artery, which I didn't know I had, and that brought me into the ER with severe chest pain, diaphoresis, nausea, and vomiting. And so now I'm actually on all the drugs that I'm going to talk about. And so when I describe angina, I describe it really well because I know what it feels like. One of the contributing factors to a narrowing artery is this concept of laminar versus turbulent flow. And this is a concept that you learned way back in physiology, but it's one of the contributing factors to endothelial cell dysfunction. And so this is kind of important to remember. This turbulent flow, which is shown here in option C, basically demonstrates that when you've got large, bulky material within the vasculature, and that material could be cells, it could be high amounts of cholesterol. Those are large molecules. They tend to partition to the periphery of the closed vessel, and when they do that, they bombard the endothelium. And the more times the endothelium gets bombarded physically by these big molecules bumping into it, that actually causes them to have a different cytoskeletal arrangement, and it actually causes them to be activated. And so you actually get a pro-inflammatory phenotype on the endothelium itself just from having excess amounts of cholesterol, and to some extent leukocytes as well, bombarding the endothelium. And so that turbulent blood flow really means something anatomically. And it's really the contributing or the driving force to this evolution of plaque formation in the coronary circuit. Okay? And so risk factors are all listed here. I don't want to spend time on this because now we're getting into pathophys. I do want you to remember that basically in terms of the right ventricle versus the left ventricle is the portion of the heart that's really responsible for sending oxygen-rich blood, bless you, oxygen-rich blood through the systemic circuit. And so when we talk about, is the heart working optimally, one of the parameters that we spend a lot of time on looking at is the left ventricle ejection fraction, because that's basically responsible for the cardiac perfusion. Okay. Likewise, if you have a myocardial infarct, there's going to be cell death. And so if you look at, and I kind of like this diagram because it shows the kind of the anatomy of the coronary circuitry. Depending on where that occlusion exists, within the coronary circuit, that's going to determine how much myocardial cell death is. And so, imagine, can you see the pointer? Imagine if the clot was right here, okay? You're only really going to probably have some ischemia in this region, and the rest of the right ventricle is going to probably be okay, okay? Likewise, if you only had a small clot right here, you would only get some cell death in this portion of the left ventricle. But imagine if you had a major clot up here, okay, right after the circumflex branches out, you would have 0 to no perfusion in this whole muscle. And this is going to be really a major heart attack, because now the left ventricle is not going to be perfused appropriately. It's going to be ischemic, and you're going to have a hard time maintaining any type of cardiac output. And so when we talk about the severity of a myocardial infarct, it really comes down to anatomically where this blood flow restriction occurred. Okay. And so this kind of reiterates that point. Is it a mild ischemia? Is it a major ischemia? And of course, if it's a myocardial cell and it's dead, it can't function, right? And so it's not going to be able to basically produce cardiac output, because there's a portion of the myocardium that's going to be dead and it's going to be non-functional. And that's kind of the main driving message here, is that this non-functional portion is really going to contribute to disease exacerbation. Okay, so that's kind of a brief kind of review of the pathophys. What we'll do is we'll put all the pathophys components back into the pharmacology portion as we go through this lecture. So some of the goals for pharmacotherapy include, reduction of elevated cholesterol. We talked about that early on in this curriculum, or in this module. We want to reduce blood pressure, because uncontrolled hypertension is going to again, kind of drive that turbulent blood flow. It's going to drive that activation of the endothelium. We want to reduce work on the heart, especially in the context of the acute MI, because the heart is going to be now overworked due to the compensatory responses that immediately occur after the myocardial infarct event. We want to reduce peripheral vascular resistance, which again kind of goes along with our goal of reducing blood pressure. If blood is thick, it's more difficult to pump, so we like to thin it. Thin blood is more water-like, and so it's easier for the heart to pump it. And then in terms of the amount of the fluid, if we reduce sodium retention, we can also kind of reduce the burden that the heart has to work, because now there's going to be less volume on board. And then, of course, that translates to less work by the heart, but also less work by the kidneys, too. So those are kind of the pharmacotherapy goals. And if you look at those goals and you superimpose the drugs that we're going to be using, it kind of makes sense. Okay, and so here's those drug classes. Again, we're going to talk about beta blockers. We're going to talk about vasodilators, ACE inhibitors, calcium channel blockers, angiotensin receptor antagonists, mineralocorticoid receptor antagonists. We're going to talk about statins again, as well as thrombolytics at the very end of this lecture series. Okay, so beta blockers. The therapeutic goal for these drugs, and maybe on this slide you can just write them in, is to reduce oxygen consumption on the heart, reduce heart rate, reduce contractility, but with the caveat that we're really only mechanistically doing this during stressful periods, okay? And so here's basically all of the adrenergic pharmacology sites. These are the drugs that can alter this. What we really want to focus on, so these are all of our potential therapeutic targets. What we really want to focus on are beta-1 receptors, okay? And then to some extent, some of the alpha-1 receptors, because we said one of our other goals was to kind of reduce total peripheral resistance, and we can accomplish that with specific alpha-1 receptors, but we can also accomplish that with the mixed-acting beta-1, alpha-1 receptors like Artenolol or Labetalol, okay? And so we're going to focus here for a little bit. And so one of the things that puzzles most students when they first learn this material is that, okay, I said there was a myocardial infarct, okay? And the immediate outcome to that is a reduction in cardiac output, okay? That reduction in cardiac output is basically due to a lack of perfusion in the myocardium, which was resulted from cell death, okay? Low cardiac output, we says, is the stimulatory event for the Renin-Angiotensin-aldosterone system, okay? Now I'm going to say our therapeutic goal for a beta blocker is to actually induce low cardiac output, So why the hell would we do that? Okay? If you don't, low cardiac output leads to, as I said, the induction of the renin-angiotensin system. Okay? Once the renin-angiotensin system gets induced, cardiac output goes up. Okay? When cardiac output goes up, the heart works harder. The cells are under more stress. More stressed cells die faster. The ischemia spreads. Once the ischemia spreads, cardiac output then goes down. Renin-angiotensin system, aldosterone system goes up even more. Cardiac output returns to normal, goes up again. And then the process continues. It's a vicious cycle. Okay? This heart is weak. It cannot and it should not do more work than it's required. Okay? If you don't treat with the beta blocker, and if you don't inhibit the renin-angiotensin-aldosterone system, this cardiac output feedback process will just spiral out of control. Cardiac output will try so hard to return to normal that it will kill the patient. Okay? And so before beta blockers and before ACE inhibitors were developed, if a patient had a heart attack, they typically died 4, 6, 8 months later because their cardiac perfusion was trying so hard to maintain this threshold, this ideal threshold that the body demands, and it can't because it physically can't, that the patient dies. And so what happens here is that the concept is that we're going to keep the cardiac output in a hypo-effective state. And the analogy is like when you break an arm or a leg, your body, the doctor puts your appendage in a cast to keep it to keep you from using it for what, 6, 8 weeks, depending on how bad the break was. So you keep it immobilized and it doesn't move for 6 to 8 weeks, and then it heals itself. Once it's healed, then you can move it. Okay? The day you come out of the cast, is that the day you join the Olympic team? No, you are not strong enough. So what do you do between coming out of the cast and entering the Olympics? You train, you exercise, you build strength, you do conditioning. And that's kind of the same process here. In the immediate aftermath of a cardiac event, like a myocardial infarct, you are basically putting the heart in a cast, and you're protecting it from doing more work than it needs to. Okay? And so, over time, and what's interesting is that, keeping the cardiac output low because of a beta blocker actually over time increases cardiac output. As the heart basically heals itself, the ischemic cells are apoptosed and are taken care of and are replaced by normal functioning cardiac myocytes. That takes months, years, depending on how bad the ischemia was. Okay? So over time, the initial outcome of a beta blocker, putting it on a naive patient, yes, reduces cardiac output, but over time you'll actually see the cardiac output going back up. Okay? Now, what is that reduction in cardiac output that initially occurs in the untreated patient? What does that mean? We said, well, earlier it's going to activate the renin-angiotensin system. Okay? The other therapeutic goal was to supply an ACE inhibitor or an ARB on that system. And so now what we're doing is we're globally suppressing both cardiac effect by keeping cardiac output slightly lower than normal, which is going to stimulate the renin-angiotensin system. And so to take care of that mechanism, then we add an ACE inhibitor. So now we're quenching that effect too. So in terms of that positive feedback loop that just spirals out of control, we're putting the brakes on 2 of the main control mechanisms. And that's the therapeutic significance of a beta blocker and an ACE inhibitor. And so in the context of the AMI patient, the number 1 therapeutic strategy is what? Beta blocker, ACE inhibitor, always. And it's like a red stamp. You have a heart attack, here's your beta blocker, here's your ACE inhibitor. We'll talk about which ones are better or worse. And remember, in terms of the heart, the beta-1 receptor is responsible for all of these increases. And so if you reduce the activity of the beta-1 receptor, you're going to reduce all of these processes. So a beta-1 receptor antagonist will reduce heart rate, okay? It will reduce the contractility, okay? And it will reduce the automaticity and so forth, all the way down to the bottom. Now, does this mean stop beta blocker? It doesn't stop heart rate, okay? It reduces it. Normal heart rate, we said, is 65, 70, 75 beats per minute, okay? What does a heart rate look like in a patient that had a heart attack with a beta blocker on board? Same, 65 to 75. Their heart rate should be normal when they're on a beta blocker. Okay? What does the heart rate look like of a beta blocker patient when they're exercising? Okay, so if you're running your heart rate should be like 150. The beta blocker patient would probably be like 90, even if they're running as hard as they can, okay? So if you see me in the gym, and I see more of you in the gym than I see you in class, which is funny, but if you see me in the gym, I don't look like I'm out of breath because my heart rate doesn't increase. So I don't run for increasing my heart rate, I just run for mileage. So I'll do like 3 miles, and I'm like, that's good. Because the heart rate's not going up. You know, so minor increases in heart rate. And that's what these drugs exist for. And so what we're doing is we're suppressing the control of epinephrine and norepinephrine during stressful periods, okay? Right now, our heart rates are about the same, okay? And what we're doing is we're preventing the beta blocker patient's heart rate from going way high, because when it goes way high, then cardiac output has to go up tremendously to accommodate that. And we don't want to, because remember, we want to keep this cardiac output kind of in the lower range, because we don't want to stress the heart too much. We don't want to make the heart work too hard. Okay, was that clear? All right. So beta blockers, in terms of their physiologic outcomes, we're going to reduce both the severity and the frequency of these attacks during exertional phases of exercise, which causes angina. All right. And then clinically, these drugs have been shown to improve survival. If we look at the 5 and the 10-year survival post-MI, the beta blockers combined with an ACE inhibitor have produced tremendous results. They decrease the amount of secondary cardiac events, and if there is a secondary cardiac event, the outcome is much better. The patient will actually live through it. Before, they never did. All right. And so here's from a physiologic perspective, there's a reduction in myocardial oxygen consumption. This is due to the negative chronotropic, inotropic, and dromotropic processes, which are listed here, of beta blockers. And then we'll talk about the use of beta blockers in different presentations of angina, but we're really referring to, you know, the the utility of beta blockers post-MI in this example. And so if you're going to reduce cardiac output, let's back up even further. What's the thing that produces cardiac output? We said it's stroke volume times heart rate. We said heart rate's going down, okay? And that's based on the antagonism of the beta-1 receptor on the pacemaker cells within the SA node, okay? So we're antagonizing that effect, so heart rate is not going to go up. But also stroke volume goes down too, and the reduction in contractility basically means that the beta blocker, which is now we're looking at the ventricular muscle specifically. We've talked about contractility, we're talking about the ventricular muscle. The beta blocker is going to reduce the intensity of each contraction. Okay, so if you think of the ventricular muscle kind of like an accordion, the beta blocker is going to reduce the ability to bring the accordion hands all the way in. Okay, that's a real large muscular contraction. The beta blocker on board will actually kind of reduce it so that it's a very slight ventricular contraction. And so if you couple those together, you're going to reduce heart rate, of course, but you're also going to reduce the oxygen demand. And so the oxygen demand is really kind of the thing that makes the post-MI so difficult for these patients to live. The heart requires so much oxygen and so much blood perfusion to do all of this work, and it physically can't because now some of these cells and some of these veins have been killed because of this ischemic event. Right? And so we said the granddad kind of beta blocker was propranolol. We don't really use that one all that often because we've developed better ones. And so the newer generation beta blockers are listed here. For the beta 1 or for the post-MI patient, we're really looking at Atenolol and Metoprolol. Atenolol is typically given in doses twice daily. Metoprolol can be given anywhere from 2 to 4 times daily. There's 2 preparations. One's a tartrate and one's a succinate. The tartrate offers immediate release, and the succinate offers extended release. The extended release really much translates to less frequent dosing. That's kind of like the take-home message. These 2 drugs have what's called, or they lack what's called intrinsic sympathomimetic activity. So these are pure beta-1 antagonists. All right, they compete with the receptor, and they reduce the physiologic outcome, which is contractility. And so they're going to compete directly with norepinephrine and epinephrine. Okay. Atenolol is probably the most frequently prescribed. Propranolol is polar compound or as a nonpolar compound, so it can get into the brain. Atenolol is polar. You get less CNS effects. You don't really see atenolol crossing the blood-brain barrier. Patients don't complain about being sleepy. There's really little variation among absorption, so you can kind of stick to a kind of a defined, well-defined dosing regimen for most of your patients across the age continuum. One thing, however, is that in renal failure patients, the drugs can accumulate, and so sometimes you have comorbid conditions where, renal disease manifests itself post-MI. There's other alternatives to atenolol, such as Metoprolol, which is very cardioselective. It is nonpolar. It can enter the brain. So patients on Metoprolol sometimes will complain of nightmares, vivid dreams. They may become depressed over time. There's very little bronchospasm because it's a very, very selective beta-1 receptor. And this is in contrast to propranolol, which was the granddad, which used to be used 20, 25, 30 years ago. There is little effect on insulin. One of the things in terms of some of these beta blockers is that, we didn't go through this because it's in the endocrine unit, is that, bless you, is that when diabetics have hypoglycemic events, some of the clinical manifestations of that would be tachycardia. And so they would know if they're hypoglycemic because their heart rate will increase. The beta blocker will sometimes mask that. So it's difficult for the diabetic patient who is also on a beta blocker for a cardiac event to know if they're hypo or hyperglycemic just based on how they feel. But there's other ways around that. We can also, because of its real potent selectivity to beta-1, we can use it in patients that have asthma as well as diabetics as well. So Metoprolol is a good drug. There's two other drugs that you can see, being used. Esmolol, really only see it used in the emergency room because it's got really a short half-life, like 10 minutes. And so you'll use it for emergency room, surgeries, urgent care type settings where you need to rapidly reduce heart rate and blood pressure. Bisoprolol is kind of reserved for kind of advanced heart failure conditions, and we'll talk about heart failure and post-MI later, but bisoprolol is a really potent beta blocker. It has both renal and hepatic elimination, and you see it in kind of exacerbations of like chronic hypertension, really exacerbated heart failure in the context of MI. But in the post-MI patient, atenolol, metoprolol would be kind of your go-to drugs. All right. For the targeted approach of going after the beta-1 receptor blockade. All right. And we said that there's other drugs out there that have mixed acting activity. So these are drugs that can block both the alpha-1 receptor and the beta-1 receptor, carvedilol, labetalol. And these drugs are really useful for the patient that has had an MI and also has a history of hypertension. Okay, because now what we can do is we can antagonize the beta-1 effect. We can control heart rate. Okay, but we can also reduce total peripheral resistance by blocking alpha-1 in the periphery. Okay, so this would be really great if the patient has hypertension and they have a heart attack. You're getting two mechanisms, okay, and two therapeutic goals with one drug. All right, so you may want to consider, and this is just kind of a review of what the receptors that control total peripheral resistance in the vasculature look like. Again, we're not going to be going after beta-2. We're going to be going after alpha-1. All right. The other things to consider in terms of beta blockers, and if you go into the book, and if you've been reading the book, there's a column here where we summarize the beta blockers. And we always talk about their intrinsic agonist activity or the intrinsic sympathomimetic activity. This basically refers to whether or not these drugs have any partial agonist activity. And if they do, that means something different therapeutically. And so the ones that have intrinsic sympathomimetic activity include pindolol, acebutolol, and these drugs have specific uses. Obviously, we haven't talked about them yet, and so we're not going to use them for the acute MI patient. We'll reserve them for another disease towards the end of the week. Another activity of beta blockers include their ability to be membrane stabilizers. And again, we haven't really talked about them yet. Atenolol has some membrane stabilizing ability, but this really refers to the use of a beta blocker to be an antiarrhythmic. And so the membrane stabilizing ability refers to the ability of the beta blocking drug to actually inhibit the sodium channel. Okay, so this is kind of a new mechanism of beta blockers, new in terms of we haven't talked about it, not new that it was discovered. And so we'll kind of reserve the membrane stabilizing activity for the beta blockers that are used in antiarrhythmics. Okay, so there's at least two other indications for beta blockers that we haven't talked about. And here's the continuation of that list because it's such a big table, it doesn't fit on one page. Okay, and so what special populations can receive beta blockers? And so this kind of goes, this is more of kind of an advanced practice type thing. You can kind of come back to this as the curriculum develops and you start putting comorbid diseases on the same patient. This will be helpful as you go back and study for your boards. Please review this slide because this will be pretty helpful. Patients that have a history of COPD or asthma, we'd like to use the beta-1 selective antagonist because we're not going to be touching the beta-2. This was demonstrated by this particular clinical trial, which is listed here. Other patients that do really well on beta blockers include these patients that have heart failure. We've got a whole lecture on heart failure and how beta blockers are useful for that disease. I already talked about diabetes. We'll talk about peripheral artery disease later, and then we'll actually do arrhythmias next week. And so these were the trials that showed beta blockers work well with other drugs for arrhythmias. Okay, so right now we've got beta blockers used in the context of glaucoma, topically, and beta blockers used in the context of post-MI. Okay, all right, so those beta blockers. Now we're going to go into ACE inhibitors, and I said the reason we wanted to use an ACE inhibitor, or at least any drug that can alter or reduce the renin-angiotensin-aldosterone system, is because that system, in the context of low cardiac perfusion, becomes so strongly activated in order to try to rescue cardiac output that it becomes a viable therapeutic target. Okay, and so first-line therapy post-MI is a beta blocker. Second-line therapy post-MI is an ACE inhibitor. Okay, and we actually had a clinical trial that now suggests first-line therapy should be both of those drugs given together at exactly the same time. Okay, and one of the things that most students have a hard time grasping with this unit is that they want to make decisions as to which drug the patient should get, and it doesn't come until much later in the curriculum that it's all of them. Okay, and so we'll talk about when you don't give them, but essentially you're going to give all of these drugs to these patients. Okay, so the treatment goal for the ACE inhibitor class is to reduce the renin-angiotensin-aldosterone activation, and that kind of drives this disease pathogenesis. And so if you have low cardiac output, and I'll just tell you the punchline before we get there, that actually puts you at stage 2 heart failure. Okay, you don't even start at stage 1 anymore. There's only 4 stages. Having an MI moves you up into the middle of heart failure. Okay, and so that's why what you're really trying to prevent is, you're trying to treat the patient post-MI, of course, but you're really trying to stop the exacerbation of heart failure, because if you don't, they're going to go forward, and eventually that heart is going to fail and give out. So here's that renin-angiotensin-aldosterone system, and one of the main outcomes to angiotensin systemically is going to be increased arterial pressure. And that was one of our treatment goals in terms of managing the post-STEMI patient, is that if we can keep arterial pressure down, if we can reduce total peripheral resistance, if we can manage hypertension, that's one of the therapeutic strategies. Okay, and so angiotensin II we said was basically kind of central to some of these disease progressions and these disease processes, and of course it has both systemic as well as renal alterations in terms of fluid retention and sodium retention. And so of course then that brings up our other drug classes that the diuretics that we talked about last week. Okay. And so what we're going to do now is we're going to go after angiotensin II. And so there's two therapeutic approaches to this. We can reduce the production of angiotensin II, which remember is the ligand, or we can reduce activation of that receptor. And so the receptor, the AT1 receptor, is located on all of these different physiologic or anatomic components. And so, we can, in this example, what we're going to do is we're going to reduce the amount of the production of the ligand, and then another therapeutic strategy would be to reduce the signaling of the receptor. So it's twofold. So we're going to stay kind of in this angiotensin II mindset. And so, a lot of the things that angiotensin II does in terms of peripheral resistance, in terms of renal function and cardiac structure, drives pathophysiology. And I'm not going to go through this whole diagram because you can read it by yourself. I like this because what it does is it tells you the mechanism of how this particular ligand drives pathophysiology. Okay? And so, again, our pharmacologic intervention strategy is to, kind of reduce this pressor response in terms of its angiotensin's effect on catecholamines. Our therapeutic strategy is to slow the response in the context of these catecholamines, which really have kind of potent activity on hemodynamics in terms of the renal vasculature. And then one other thing that we haven't really talked about is the mechanism of hemodynamics in terms of the ventricular remodeling and hypertrophy. And so when there's an ischemic event, okay, and the ventricular muscle dies, it can and sometimes does go under what's called ventricular remodeling. And so this is the implantation of fibrous type tissue, okay, and this is a reorganization of the extracellular matrix. Okay, this is a twofold mechanism because now the ventricular muscle doesn't have as much stretch that it used to, and so because of that, you get a lot of muscle stress and wear and tear. When that occurs, that's the increased amount of reactive oxygen species, which actually causes further muscle damage and muscle death. And so one of the cool components of ACE inhibitor therapy is that they actually kind of reduce the ventricular remodeling that's usually associated with post-MI. And so we don't exactly know all of the factors, but we do know, some of them are listed here. The expression of proto-oncogenes, and so these are going to look at DNA damage, increased production of growth factors, and so somehow mechanistically these ACE inhibitors inhibit that. And so some of these are described well in the literature, some of these are not quite so understood, but we know that when patients are on an ACE inhibitor, the cardiac hypertrophy and remodeling that we can see both on imaging as well as on pathology evaluation seem to be much more dramatically reduced when a patient takes an ACE inhibitor. Okay? So it's a great target, and we said we were using ACE inhibitors for hypertension, so that hypertensive lecture that we talked about, when was it, last week? Right? So, the reason you're going to use ACE inhibitors is, basically now the same, okay? So now we've got a hypertensive patient that had an MI, or we're going to have an MI patient who may be at higher risk for hypertension due to this reduction in cardiac output that they're experiencing. Okay, all of the ACE inhibitors, remember, have the suffix pril. They're all listed here. And we said last week that essentially the ACE inhibitors are equally efficacious. We don't really break them down like we do the beta blockers. And so, you can pretty much use any of those. There's some nuances to them, but it's nothing that I don't think I need to test you on. There's really a dual mechanism of action here. So we're going to inhibit the enzyme ACE, and that's going to prevent the conversion of bradykinin to its inactive peptides. Remember, bradykinin has a whole host of immune type and homeostatic type control mechanisms, which we'll talk about maybe in the next 3 or 4 lectures again and again. And it's also, and its main therapeutic goal is to inhibit angiotensin I conversion into angiotensin II. So angiotensin I is the kind of the early pro-protein, and then angiotensin II is the protein that actually has biological function. Okay, you can classify the ACE inhibitors based on their chemistry, which is interesting from a pharmacology perspective, but clinically useless, so don't worry about that. And then these are all of the clinical indications for ACE inhibitors. And so we already talked about hypertension. we already talked about, or we're talking about right now, acute myocardial infarct. And then we're going to return to ACE inhibitors next week when we talk about heart failure. They're, again, one of the frontline therapies for heart failure. So now when we say a patient's on an ACE inhibitor, what can you automatically assume based on their patient history? They had either what? Going backwards from this lecture. They have either hypertension or they had an acute myocardial infarct, or both, okay? And then if the patient has exacerbation of disease, they can see systolic dysfunction, which is indicative of heart failure, and so that's the third group of patients that would be put on an ACE inhibitors. And then as we go through the curriculum, diabetic patients that have a higher incidence of hypertension anyway also should be put on an ACE inhibitor. And then patients who are at high risk for cardiovascular events, think of overweight, edematous, and smoking patients. All right. And so these ACE inhibitors have an inhibitory effect on the renin-angiotensin system. We're going to basically reduce blood pressure by inhibiting this system. And we're also going to negatively affect aldosterone secretion. And so that's kind of another therapeutic benefit to some of these ACE inhibitors. Okay, so we're going to decrease peripheral resistance. It's been shown that ACE inhibitors work better in patients with left ventricular failure but no edema. Okay, this is a key point for the heart failure component, but it's also one of the key factors in terms of putting a patient on post-MI. If there's dramatic heart failure with no presentation of edema, you can still use it, but it may not give you the most bang for your buck. Cardiac output and heart rate are not changed. That's important because with the beta antagonism, cardiac output and heart rate are changed, okay? And so remember going back to the Goldie-Coleman hypothesis, which we usually kind of ascribe to chemotherapy. The concept is the same here. You've got two different mechanisms of action, right? Non-overlapping toxicities. If the main toxicity to an ACE inhibitor was low heart rate, it wouldn't make sense to use them with a beta blocker, but it doesn't produce that, which is why these drugs work so well synergistically. And of course, there's an indirect vasodilator response, which will continue about as we go through this curriculum. Don't worry about that just yet. Okay. Well, what are some of the side effects? You can with an ACE inhibitor, you can get hypotension during periods of hypovolemia. So what does that look like? So if they overdosed on a diuretic, if there was dramatic fluid loss, like in the context of they have like a GI infection, like a GI viral infection, and they have profuse diarrhea, that's a change in physiology that's abrupt enough to produce hypotension. And so how would you manage that? Well, if the patient tells you that, they're on all these drugs and they've got a GI type bug, well, you might want to say, okay, maybe for the next 3 or 4 days, maybe stop taking your ACE inhibitor, because we don't want to have you have a hypotensive crisis, okay? Likewise, with the beta blockers, you do not tell the patients to stop taking their beta blocker. They will have a very bad side effect and very bad outcome. You never, ever abruptly withdraw a beta blocker, okay? And we'll talk about that in the side effect lecture. The main outcome to ACE inhibitor therapies in terms of side effects include this dry cough. Sometimes you hear it called the captopril cough. It's just kind of easy to remember. And of course, changes in potassium. And so sometimes you'll see hyperkalemia with these patients. The therapeutic targets now, we're looking basically at the ability of these ACE inhibitors to stop the production of angiotensin II, which we said was the ligand. And remember now, our beta blocker is also going to have an inhibitory effect on renin activity because the beta blocker is going to block the beta-1 receptor on the juxtaglomerular cell, okay? And that is going to be the thing that kind of drives renin secretion. And so you get kind of a twofold hit with a beta blocker. So you'll control heart rate and cardiac output, but you'll also reduce kind of the building block of this renin-angiotensin system by inhibiting renin secretion, okay? What's the other drug class that's listed here? And that's to remind you that, of course, we can employ our diuretic agents. And so what are the two diuretics that are used for for the heart diseases that we're going to be talking about. One obviously is thiazides, and what's the other one? Loop diuretics. Okay. By the way, a couple of you have asked specific questions on carbonic anhydrase inhibitors. I'll get to your questions. It's not that important of a drug class. I mean, I know you guys are like taking this seriously, which is awesome. I commend you for that. But we're not going to use that drug in this lecture series. When to use carbonic anhydrase inhibitors? Glaucoma. Okay. And so if it's in glaucoma, it's topically. Okay. And then the other one would be like elevation sickness. And so what I've done is I've decided to put most of the diuretic, the real chunky parts of diuretics, in the kidney lecture series. And so when we start talking about acid-base chemistry, we'll talk about diuretics specifically on the sodium transporter pump and, you know, potassium, sodium in, calcium out, all that business. I want to stay focused on the immediate effects of the cardiovasculature right now. And I know kidneys are involved, but let's not go to the level of nephron yet. So I have a couple of notes in here about the differences between some of these beta blockers, some of these ACE inhibitors. And, you know, and this is really just kind of for your reading material. This is what some of this will look like. Typically with Enalapril, you see it really indicated for initiation therapy because it's really kind of well tolerated. There was another, yeah, because it sticks around for a long time. The other drugs, Lisinopril, this one's biologically active. Enalapril has to be biologically converted into something. That's where maybe you might see some drug-drug interactions, depending on what other drugs the patients are on. The nice thing about Lisinopril is that it doesn't really kind of accumulate in tissues, and it's relatively cheap. Patients really don't mind being on it. It's readily accessible. Benazepril has kind of some other unique pharmacology. This one would maybe some food alterations and so forth in terms of its absorption qualities. But these would be kind of some of the things that you would really kind of think about with the ACE inhibitors is, does the patient have any kind of renal or hepatic insufficiency? And is the ACE inhibitor that you chose, is it primarily renally cleared? Is it hepatically cleared? Is it both? How much is it? How long does it stick around? Is the patient compliant? Is it once a day dosing or twice a day dosing? Those are the kind of things that you would kind of consider with the ACE inhibitors. At this level, what we do is, you know, if the answer choice is an ACE inhibitor, there's only going to be one. You pick the ACE inhibitor. I'm not really going to have you quantify which ACE inhibitor is better than the other because it's essentially subjective. Okay? But I will have you determine which beta blocker is better than the other because that actually is more clinically relevant, and there's a lot to choose from. Okay, Ramipril is listed here. People like to talk about Ramipril from a pharmacology perspective because it has a triphasic elimination, and so there's 3 different phases of elimination. And so again, if you follow that rule of 5 or 6 in terms of the number of half-lives for the drug to be eliminated, this one doesn't actually follow that rule because it's got 3 different phases, and so 3 different metabolites will be, you know, sitting around in the blood for different periods of time. So from a kinetic standpoint, it's unique, but you know, it's just neither here nor there. It's just kind of interesting. Okay, so what we've been doing now is with our ACE inhibitor, we've been basically inhibiting the biological conversion of angiotensin I to angiotensin II, okay? And so we're essentially stopping the ligand, right? So the other thing that we have to kind of remember is that there's this receptor down here on the receiving end in all these anatomic compartments that angiotensin II produces a physiologic effect. And so what we can do is another therapeutic approach would be, instead of using an ACE inhibitor, to use something like an ARB, or an angiotensin receptor antagonist. Okay, and the reason we developed ARBs was because there's 2 main side effects to ACE inhibitors that just are horrible, and patients don't ever want to experience again after this happens. And one is angioedema, and the other one is cough, this persistent captopril cough, or this persistent bronchospasm. All right, and so these are really kind of the 2 side effects that reduce patient compliance on an otherwise pretty wonderful drug. Okay, and so what we've done is now we've created another drug class, the ARBs, specifically for these patients. What is interesting is that even though we created the ARBs to kind of alleviate this the side effect of angioedema, both of which these side effects are believed to arise from the fact from the fact that we've kind of altered bradykinin activity. That was the hypothesis. But as you'll soon find out, that hypothesis was proven to be wrong. So even though we made ARBs for the context of angioedema, we don't give ARBs for the angioedema patient that, or for the ACE inhibitor patient that experienced an angioedema. We thought it was going to be fine, but in spite of that, they still may have a recurrent of angioedema. So we don't really know the mechanism of how that occurred. But these drugs were kind of produced for that reason, but it kind of backfired. Doesn't mean they're bad drugs, but it just, you know, it was interesting. And the reason that the bradykinin, we think, plays a role in that kind of stems from that this bradykinin has, you know, multiple signaling pathways. Here it's shown binding to a beta-2 receptor, but it also can hit other inflammatory-like type receptors and chemokines and so forth. And the outcome is going to be edema, vasodilation, increased permeability in terms of the endothelium and so forth. And so that's kind of the contributing factor to this persistent cough and possibly to the production of angioedema. And the angioedema has really manifested itself kind of in the lips. You can also see it within the arms itself, but it's more prominent in the lips. And so if the patient comes in and they were on an ACE inhibitor and they've got this reaction, this is really where that's coming from. This can happen. What's weird about the angioedema reaction, and this is kind of cutting into my side effect lecture, but who cares, is that it can happen 2 days after the ACE inhibitor is initiated or 18 months after the ACE inhibitor is initiated. And so it just happens with relatively low %, but when it does happen, it's kind of annoying from the patient. All right. And so the frontline therapy right now post-MI is beta blocker, okay? And at this point, it could be beta-1 specific blocker, or it could be a mixed-acting beta blocker. Either of those would be probably equally efficacious. The main thing would be whether or not there's any underlying hypertension. If there was underlying hypertension, I would say maybe choose the mixed-acting alpha-1 beta blocker like carvedilol. If there's no underlying hypertension, metoprolol would probably, or atenolol would be just fine. All right. ACE inhibitor would be the other drug of choice. Whichever one's cheapest, okay? Whichever one is on your formulary for whatever hospital you're in, okay? And then if the ACE inhibitor doesn't work, if the patient has maybe a persistent cough that they complain about, then you can use an ARB. But an ACE inhibitor is kind of the frontline therapy, okay? So, you know, in the 12 hours after the myocardial infarct, they're more likely than not be put on the ACE inhibitor. You know, once the angioedema reaction or once the cough reaction occurs and the patients start complaining about maybe you know, some side effects of the ACE inhibitor, then you can start thinking about implementing the ARB. Okay, and so the ARBs are another kind of molecular target to inhibit the renin-angiotensin-aldosterone system for patients, specifically for patients for whatever reason that are intolerant of the ACE inhibitor. Okay. Oh, it's 11. Let's take a break. You guys look like you need it. Okay. All right. So we did beta blockers, we did ACE inhibitors. So now ARBs are the alternative to the ACE inhibitor. You don't really use ACEs and ARBs together. If you look in the medical literature, if you go to PubMed, you can probably find a patient or two that were treated like that, but right now it's contraindicated. You wouldn't really want to use them together because they actually have, even though different quote-unquote mechanism of action, they do have kind of overlapping toxicities. And so that's one of the reasons you wouldn't want to use them. The ARBs are the angiotensin II receptor antagonists. This nomenclature gets confusing. It's the angiotensin II, Roman numeral 2, receptor antagonist. This refers to the ligand, okay? But it binds to the AT1 Arabic numeral receptor, okay? So the angiotensin II ligand receptor antagonist binds to the angiotensin subtype 1 receptor, okay, with high affinity, okay? And these are the sartans, okay? And these are G proteins, and so they have a kind of a similar signaling pathway, utilizing GQ to activate phospholipase C through that calcium pathway. If you notice, I didn't really have a lot of questions on the molecular biology on MOD, okay? And I did that because I know clinically you don't need to know that, but in terms of understanding pharmacology, you should at least get it once. Okay, so that was kind of like my present to you, even though it didn't seem like a present. I have a friend who's a physician, and he didn't know how these things worked because his medical school was not nice like ours and told him all this stuff. And so I was like, well, you know what, I'm going to teach them how it works so that they have it once. And so you learned it once, put it in the back of your brain. Now you know where it exists, but you don't have to memorize it for any kind of exam. All right. And so this is the signaling pathway. So GQ activation, phosphokinase C, and then all these other eicosanoids basically producing this calcium calmodulin dependent activity. And so we'll kind of revisit this molecular pathway when we talk about the vasodilators coming up next. All right. So these are the sartans, and like the ACE inhibitors, the sartans really have kind of no difference in terms of their biological activity. They're essentially all equally efficacious, but they don't affect bradykinin metabolism, and so that's one kind of a key component in terms of their differences. They're more selective than the ACE inhibitors, but the pharmacology in terms of their physiologic outcome is pretty similar to the ACE inhibitors. The incidence of cough and the incidence of angioedema, which were the two kind of common side effects plaguing patients on ACE inhibitors, are much less common with an ARB. And so these ARBs are kind of the second line therapy when the ACE inhibitor is contraindicated or not tolerated, more often not tolerated. Okay. And so here's kind of just looking at the pharmacology. You can read this on your own. I don't want to get too detail oriented, but for those of you who like the physical, which one binds to which and which receptor and so forth, it's all here. So here is kind of a review. We talked about our ACE inhibitors, reducing the production of the ligand. We're going to talk about the ARBs and their ability to disrupt basically the molecular signaling inside some of those effector cells that are responding to angiotensin II. So one key difference that you should kind of remember between them is that the ARBs essentially reduce the activity of the receptor to be signaled. It doesn't affect angiotensin II. And so all of the other things that angiotensin can do in the body will still occur through a different receptor. So angiotensin II doesn't just bind to the AT1 receptor, it binds to other things. So that means this ligand can do other physiologic outcomes as well. So that's the other key concept between these two drugs. What I liked about this particular summary slide, and this is from Goodman and Gilman, is it basically is comparing your ACE inhibitors and your ARBs, and in terms of their mechanism of action, their main effect, and their clinical applications. Okay, so essentially they're a lot in common, but some nuances in terms of their differences. All right. So right now, our patient is on a beta blocker, they're on an ACE or an ARB, and then now the next group of drugs are the aldosterone antagonists. And so this is a special group of patients. Treatment rationale here is patients that have had an MI that are also showing symptoms of heart failure. And that looks like volume overload in spite of being on an ACE inhibitor. Okay? And so the ACE inhibitor will have some vasodilatory effects as well. And so these patients now have volume overload. They had an MI. We haven't talked about heart failure yet, but they're basically showing exacerbation of disease. And heart failure is kind of an exacerbation of that's brought on by acute MI. There's only two aldosterone antagonists, really, eplerenone and spironolactone. Spironolactone is probably more common. And mechanistically, what we're doing is we're inhibiting sodium reabsorption, okay? And we'll use these kind of in the first 2 weeks following an MI in patients that are on an ACE inhibitor who are still showing reduced left ventricle ejection fraction. And so that's kind of the hallmark measuring tape, so to speak, of patients that have MI-induced heart failure. Okay? And so spironolactone is kind of reserved for a special group of patients. So let's kind of talk about other treatment approaches. Let's go to the calcium channel blockers. Okay, so what's the treatment rationale here? Reduce oxygen consumption on the heart for patients that are intolerant of beta blockers. So the patient has an MI, they get a beta blocker, they get an ACE inhibitor, okay? What other drug should they get based on your lecture last week? We were just talking about this. Statins, right? Okay, so they get a beta blocker, they get an ACE inhibitor, they get a statin, right? At some point, they start complaining about low heart rate. They start complaining about exercise intolerance. So you may want to consider, okay, maybe a calcium channel blocker would be a good alternative. And that's exactly what these are. So these calcium channel blockers are kind of good alternatives to beta blockers in the context of reducing oxygen consumption, okay? The problem is that there's actually two relatively different types of calcium channel blockers that are out there. They're basically chemically defined. So there's the dihydropyridines and the non-dihydropyridines, okay? And the dihydropyridines are essentially peripherally acting calcium channel blockers. These have relatively very little cardiac effect, all right? So if you're going to replace your beta blocker, you would most likely use one of the calcium channel blockers from the non-dihydropyridine class, which is also a vasodilator, but is more cardiac specific, okay? And so these calcium channel blockers are going to reduce calcium signals, okay, from the sarcoplasmic reticulum. And again, remember we said if there's less calcium inside the cardiac myocyte, there's less energy in the form of calcium to have a sustained contraction. Okay, so the beta blocker reduced calcium through its beta-1 receptor. The calcium channel blocker is going to reduce calcium through altering the calcium channel. Okay, and these are used for different versions of angina. So you'll see these calcium channel blockers in the next lecture again. Again, you could use them for MI. They're not kind of the frontline therapy. They're kind of the second-line therapy for beta blocker intolerant patients. And they're also seen in hypertension, which we didn't really talk about, but they were kind of reserved for like third-line therapy as well as heart failure. Okay, so in the context of all these diseases, where can you see calcium channel blockers? Pretty much every lecture. Okay, and this is how they work. So there's going to be direct actions, and this is coming from calcium antagonism, all right, and that's going to promote vasodilation, and that's going to promote vasodilation in the systemic arterioles as well as in the coronary arteries. So if you vasodilate the coronary arteries, you're actually opening up the gate to let more blood flow into the heart so that it can work harder when it needs to. There's going to be a reduction in arterial pressure, and there's going to be a reduction in coronary vascular resistance, okay? The contractility of the myocardium, its ability to be an accordion and have all of that force push the blood out, is going to be depressed because there's going to be less calcium within those cardiac myocytes. Conduction velocity between the SA to the AV node will be severely restricted because that is dependent upon the amount of calcium within those two cells. And that's why calcium channel blockers are good antiarrhythmics. So here's again that signal cascade that we're going to be inhibiting. And so diltiazem and verapamil, all right, mostly block the conduction velocity at the SA node, all right, and they're pretty good vasodilators in terms of the periphery with inhibitory effects on contractility. So these are the two calcium channel blockers that you might want to consider, maybe in place of a beta blocker. Okay, for whatever reason, the patient doesn't like being on the beta blocker, they're intolerant of it, and so forth. Amlodipine and feldipine and other drugs in that category don't really have any type of cardiac-specific inhibition, but they are good vasodilators in terms of the periphery. And so the patient with persistent hypertension that's possibly, maybe already on a thiazide, you might want to consider adding something like amlodipine to kind of give a two different mechanistic approach to reducing total peripheral vascular resistance and increasing vasodilation. And nifedipine, which is in that same category, they all have the suffix pine at the end of it, has really kind of the most bang for your buck in terms of its ability to be a vasodilator. All right. So again, this is from Goodman and Gilman. Oh, this is from Katzong, sorry. And essentially what this is looking at is just kind of comparing these two different drug classes. All right. There's a new calcium channel blocker or sodium channel blocker that's on the market. It's renozoline or Renexa, and basically it basically inhibits the late sodium current pump. Really, it's there to kind of prevent or reverse the ventricular remodeling that can occur post-MI and as the patient progresses through heart failure. Doesn't really affect heart rate or chronotropy, but it kind of increases coronary blood flow. I don't exactly know completely how this works because it's a relatively new drug, but you will start seeing this drug in more and more clinical trials in the next couple of years, talking about having this move up in terms of it being kind of reserved to more maybe frontline therapy. And we think it's really kind of a mechanistic effect in terms of the sodium channel on the ability of these myocytes to undergo this, the Krebs cycle that leads to basically free energy. So you kind of shift energy production away from fatty acid oxidation towards glucose oxidation, and you kind of make the muscle work a little bit easier in terms of its ability to use energy. So that's kind of how we know how it works, but you'll see more information coming through your CME credits in terms of how this drug relates to specific cardiac diseases. All right. One thing that we know that it can do is it prolongs the QT interval, and so originally they were kind of thinking maybe it might be an antiarrhythmic. This says it might be as well, but you don't really want to have it with specific drugs, and so there's some drug-drug interactions that they have to kind of pan out before they use it. So it's kind of the new kid on the block in terms of calcium and sodium channel blockade. All right. So the post-MI patient is on a beta blocker. If the beta blocker doesn't work, we give them a calcium channel blocker. They're on a ACE inhibitor. If the ACE inhibitor doesn't work or they don't like it, we can give them an ARB. If they show persistent volume overload, we can think about adding something like spironolactone, which is an aldosterone antagonist. Okay. If they had a heart attack and it was due to a occluded coronary vessel, and that occlusion had lots of cholesterol, we can look at their HDL and their LDL numbers. And if they're high LDL, low HDL, we can employ a statin. Okay. And in fact, clinical trials have shown that even if the patient's statin level or cholesterol levels are kind of near normal, they still benefit from being on a statin anyway. So it's kind of like your consolation prize for having a heart attack. Here's your statin, take one to go. The treatment rationale here is we're going to reduce LDL, we're going to raise HDL, which is really hard to do. How do you raise HDL? Your HDLs are probably, if you go to the gym, your HDLs are probably pretty high. Okay, so working out, lifting weights, running, exercise, that'll raise HDL. Reducing LDL is, again, accomplished by reduced weight, reduced calorie intake, less pastries. That's my problem, is pastries. I see a cheesecake and I can't say no. So I just take an extra statin and everybody's happy. And so what's been shown is that when you give a patient a statin, you actually reduce the number of cardiac events post-MI. Mechanistically, and you guys remember this from the statin lecture that was recorded, we're going to inhibit cholesterol production by inhibiting kind of the first step in cholesterol synthesis, and that's inhibiting HMG-CoA reductase, which is kind of the rate-limiting step in terms of cholesterol production. And so we're going to reduce LDL, and we're also going to consequently increase the LDL receptor. And so that's one of the key kind of physiologic outcomes in terms of persistent ligand inhibition. And this is across the board for almost any drug, not just statins. But when you reduce the amount of available ligand, the body compensates by increasing the amount of receptors because it thinks that that it's deficient in terms of its receptors, and it needs to catch all the ligand that exists out there. If the ligand doesn't exist, it's being inhibited biochemically, and so you'll see an upregulation of the LDL receptor in a patient that's on a statin. What are the statins? Lovastatin, atorvastatin, all of them shown here. Which one is the most efficacious? That actually is known. Right now, Crestor, rosuvastatin, is probably the most efficacious in terms of lowering LDL. As you go into the clinics, and I didn't supply it here because it's relatively easy to look up, but there's a guide that says, what's the patient's LDL, and then what's the target. And so if the target is a reduction of 20%, these are the drugs that you can use that will reduce LDL by 20%. If the target's 80%, these are the drugs that you should use, and then they give you a dosing guideline too. So, you know, rosuvastatin is probably, I think, the most potent. It gives you the most bang for your buck, even at the lowest dose. Lovastatin or atorvastatin are, you know, kind of on the lower to the middle of that end. And so if you need a slight reduction in cholesterol, you can probably pick any of them. If you need a dramatic reduction in LDL, rosuvastatin is probably your guy. Or girl. I don't know if it's a guy or a girl. Other things to consider, some of the older members are administered as a prodrug, and those are listed here. That basically means that the drug is not biologically active. It needs to be activated. It doesn't really mean much in terms of a single drug being administered, but when you've got drug-drug interactions and you've got, think of like CYP3A inhibitors and inducers, that might be a potential drug interaction. And so you might be prescribing them 80 milligrams of lovastatin, but in reality, they're only getting 5 of it because part of the biotransformation is being inhibited by another drug that you're giving for a different reason, maybe depression or you know, something like that. What's interesting is that these drugs have a high first pass extraction, which is great because they're actually at the site of the extraction. And so the high first pass effect basically means that an oral tablet has a huge portion of that dose going to the liver, but the site of cholesterol synthesis is the liver. And so you get this huge deposition of these drugs at the site where the molecular target exists, which is why these drugs work so well. All right. Typically, we like to give them at night because that's, you know, when you're sleeping is when we think cholesterol synthesis occurs. If the patient works the night shift, you may want to have them take it before they lay down in the morning. And here we can see basically really good reduction in LDL, but also a small gain in HDL. And so this is actually clinically useful because now essentially what you're doing is you're shunting some of that free cholesterol away from the circulation, which is where it's being problematic, to tissue deposition. And you also can see a kind of a modest reduction in triglycerides. But, you know, in terms of LDL and its ability to target LDL, these are really the most potent LDL-lowering drugs that exist. What we found is that when you combine the statins, they actually can work synergistically with other drugs. So there are some patients, no matter what you give them in terms of their statin dose, you still are not reaching target LDL and HDL levels. And so you may want to consider one of the other anti-cholesterol medications, maybe a statin in combination with a resin or a statin in combination with Zetia. The niacin is kind of falling out of favor. Has Dr. Shaw talked about niacin at all with you guys? No? We'll talk about it. Niacin's really kind of fallen out of favor. The resins and the Zetia, which is ezetimibe, these have been shown to work really good in terms of working synergistically with the statin to really dramatically reduce cholesterol levels. We don't give them, obviously, to women who are pregnant or may become pregnant or lactating or breastfeeding. And in severe cases, we can actually give these drugs to children that have these kind of familial weird hypercholesterolemias that are, you know, genetically induced. It's not that the kid is living on chocolate chip cookies, although that might contribute to it. I wonder if my kid's diet of chocolate chip cookies and ice cream is going to contribute to their statin level or their LDL levels, but so far so good. Okay. In terms of toxicity, probably the main toxicity and the kind of the dose limiting thing that most people kind of complain about is this rhabdomyolysis. And so this is an accumulation of myoglobinuria. When it's left untreated, it can produce renal failure, which is really serious. But most patients on statins really kind of complain of muscle weakness. And so this is kind of a soreness or a nondescript, non-localized muscle achiness in their legs. It's more kind of bothersome than it is medically urgent. But this reduces compliance with the statin. Now I'm on a statin, of course. A couple of months ago, a couple of years ago, when I threw out my back, I went off the statin for 3 months while the back was healing, just because this persistent muscle weakness was just really kind of annoying. Interesting side note: we think that the muscle weakness and some of these other non-canonical functions of statins really comes from these two pathways down here. Basically, when you inhibit when you inhibit HMG with a statin, you stop this whole pathway. We think these pathways are responsible for the side effects. Just as an added plug, I research some of these non-canonical pathways, and we're looking at using statins for targeting this pathway in terms of disrupting the chemokine communication between cancer cells and between immune cells. And so that's going to be published hopefully this year if the damn reviewer gets their act together. And so essentially what we're doing now is we're going back to kind of that atherosclerotic plaque. And so this was kind of the thing that was driving home a lot of our problems in terms of coronary artery circulation. This oxidized LDL, or this free LDL, was the thing that contributed to endothelial cell activation, which leads to monocyte recruitment. When these monocytes come into contact with free LDL, they turn into foam cells, and these foam cells really drive this plaque formation. They're a major player in a lot of these processes. And so by reducing the amount of free LDL within the blood, we're reducing the ability of these monocytes to A, even be recruited, and B, get turned into foam cells. And so this is kind of like an early kind of preventive type measure in terms of stopping this plaque formation. All right. And the other part of plaque formation, the consequence of this, is this formation of a thrombus. And so the clot was the thing that actually produced the MI, right? And so you can see the inflamed endothelium was responsible for a narrowing of the vessel, right? Because if you look at this vessel is getting more and more narrow as you go through these processes. But the clot is the thing that actually stopped the blood flow, and that's the thing that produced the myocardial infarct, right? Because no blood through that vessel led to ischemia and cell death out here. Okay, so the final group of drugs that we're going to talk about are the anticoagulants in the MI patient. And so just as a review, our MI patient is on a beta blocker, right, an ACE inhibitor, and a statin, right? And then we've got drugs underneath that. For whatever reason they can't take option A, there's an option B, all right? So now this is the fourth group of drugs that they're going to take, and that is drugs that can basically reduce the effect of platelet aggregation and activation, and we're going to reduce and prevent the number and size of vascular clots. And that drug is aspirin, all right? And then we've got a few other drugs that kind of have similar therapeutic consequences, but the fourth drug that your patient should be on is a low-dose aspirin, okay? Looking at all of the different molecular targets in terms of basically kind of preventing the activated endothelium from contributing to atherosclerosis and the formation of these plaques. These are all those key kind of physiologic mediators. And we're going to come back to this, this information again and again when we talk about anticoagulants in much more detail. We've left out warfarin, we've left out Coumadin, I'm sorry, those are the same ones. We've left out heparin and all of the injectables. We're really only focusing on the anticoagulants for the acute MI patient. Okay. Boys, I've been at a conference the last 4 or 5 days, and there's nothing left. So, and remember from biochemistry, we talked about well, I didn't talk about it, but Dr. Sasabo did, the COX-1, the COX-2 differences. And remember, COX-1 is the constitutively expressed enzyme that's responsible for inflammation, and the COX-2 is the one that's inducible upon inflammation. So these are all the different drugs that can be used post-MI to basically restabilize hemodynamic physiology. And so aspirin is really a COX-1 inhibitor, okay? And when COX-1 is active, it really allows these platelets to adhere to the activated endothelium and recruit their friends. And so aspirin is a viable target in terms of preventing further clot formation. The other two groups of drugs are these ticlopidine and prasugrel, and these bind to the ADP receptor, which is on platelets, and that also assists in platelet recruitment and activation. And so these two processes, through different mediators, have the same physiologic outcome, okay? And so in terms of our post-MI patient, having an aspirin on board as well as having one of these on board gives kind of a twofold inhibition of platelet recruitment and activation. And that's really our main therapeutic target, platelet recruitment and activation, and we can inhibit it by using these two drugs. We can also inhibit it by using some of these monoclonal antibodies, but again, these are more costly, and these two drugs are so effective that we seldom have to kind of go into this realm right here. And these are, again, reserved for those special patients for a variety of reasons that can't take either of these two other choices. And so in order of frequency, in terms of how frequent will you see them in the post-MI patient, aspirin, ticlopidine, and then the third option is listed right here. There was a clinical trial that showed aspirin plus ticlopidine or clopidogrel worked kind of synergistically, and that's what you'll see. So the fifth group of drugs that a post-MI patient will be on is this group right here, ticlopidine, cancrelor, ticagrelor, some of these other ones listed right here. So let's talk about aspirin for a little bit. Reduces both the incidence of myocardial infarcts as well as prevents death in patients with unstable angina. So we'll talk about aspirin again tomorrow. It seems that low doses of aspirin are much more clinically relevant for the post-MI patients because they reduce the incidence of heart attack in patients with stable chronic angina. And the higher level doses, even though they work, they also are associated with kind of an increase in side effect. And so the bare minimum dose for the post-MI patient is 81 milligrams. Typically, physicians think a little more is better. So in the immediate time of the heart attack, you'll see them being prescribed 162 or 325 milligrams for maybe 6 months. And then, after that, they'll be reduced down to 81 milligrams. Aspirin is really fast oral absorption and really quick distribution throughout the tissues. You've seen the Facebook memes. I'm sure your aunt or your mom and dad post that, if you feel the heart attack symptoms coming on, take an aspirin. I did not take an aspirin during mine because we didn't even have aspirin in the house because millennials don't take aspirin. We take Tylenol or ibuprofen. But now I take aspirin. And apparently I was shocked to find out I was still in your age category. I was the first millennial. I was born in '82. Aspirin really mechanistically is a direct antagonist on the prostaglandin thromboxane pathway, and it's an irreversible inhibitor of the COX enzyme. It acetylates it. Okay. We'll talk about aspirin throughout the curriculum because it is a pain reliever, it's a fever reducer, and it is an NSAID. Okay, but we're using it not as any of those. We're using it in terms of its ability to block platelet activation. And so the dose ranges are here, and you can see patients can and have taken high doses of aspirin for the anti-inflammatory effects. The problem is that the side effect profile starts to manifest itself within the intermediate dose range. And so, very few people are taking 4,000 milligrams of aspirin daily just because the side effect profile in terms of irritation of the GI mucosa is so bad. What is key to remember is that the inhibition of the COX enzyme on the platelet itself is basically irreversible. And so how long does a platelet live? 7 to 10 days, maybe 12 days, depending on who you read. So when that aspirin molecule hits that platelet, it renders that COX enzyme inactive for the life of the platelet. Okay? And so when you talk about how long does aspirin persist, well, it persists as long as the last dose of aspirin hit the last group of platelets. So from that point on, it could be 7 to 10 days. Okay? So the drug isn't floating around the serum for 7 to 10 days. The enzyme is inhibited due to the drug bound to the enzyme for 7 to 10 days. All right? For the cardiac patient, we give typically low-dose aspirin. We used to call it the baby aspirin. Why don't we call it baby aspirin anymore? Because of a rare syndrome when you give children aspirin in the context of a viral infection called Ray's syndrome. Okay, so baby aspirin used to be maybe what your parents and my grandparents used to call the 81 milligram dose. We don't give children aspirin anymore. There's a specific indication for giving a kid an aspirin, but usually if there's a viral infection on board, that offers the ability of this rare syndrome, the Ray's syndrome, to manifest itself. And typically when you have a virus, you have a high temperature, and so that's when the parents would give the aspirin anyway. So now we don't give baby aspirin, we don't give babies aspirin anymore. Here's that arachidonic acid pathway, and both COX-1 and COX-2 convert arachidonic acid into this prostaglandin precursor. And so when you inhibit COX enzymes, either 1 or 2, you're really inhibiting all of these prostaglandins. And so when we talk about some of the side effects to aspirin therapy, it really stems from some of these other prostaglandins being inhibited. Okay, and this is in terms of the systemic activity. When we're talking about aspirin for the MI patient, we're really focusing on COX-1 inhibition and in terms of how it relates to thromboxane A2 activity, which promotes platelet adherence and sticking to each other in an inflamed endothelium. So the main toxicities to aspirin include bleeding and gastric upset, and those are the two dose-limiting toxicities to using drugs like aspirin as an anti-inflammatory drug. So chronic use of these drugs can lead to gastric ulceration, upper GI bleeding, as well as renal effects. Okay, and that's another reason not to kind of push the dose of aspirin for the post-MI patient, is that it's not needed. We don't need to inhibit all these prostaglandins down here. We really only kind of need to go after the thromboxane A2 pathway, and that's actually accomplished quite well with a low-dose aspirin. The low-dose aspirin really manifests this quite well. It's when you start to increase the dose, you start to affect these other pathways more frequently. Okay, so mechanistically we can inhibit the COX enzyme with an aspirin. That inhibits platelet activation and platelets sticking to each other. Another mechanistic approach would be looking at ADP receptor inhibition, and these platelets contain two G protein coupled receptors called P2Y1 and P2Y12. These are G protein coupled receptors. And when you block these receptors, you're essentially blocking the process of platelet activation. And this is, again, through an adenylate cyclase cyclic level AMP activity. So this is the pathway that you're familiar with. But now we're on the level of the platelet and its ability to stick to another platelet. All right. And so Plavix, and this is one of those weird drugs, clopidogrel, kind of hard to say, and it's even more hard to spell. Plavix is just kind of used clinically, even in the context of pharmacology. Just clopidogrel doesn't roll off the tongue. Clopidogrel kind of replaced taclopidine. Nobody uses taclopidine anymore. And it's more potent. And so the reason is that there's a more favorable toxicity profile with clopidogrel, and so that's why it's kind of more common. And so essentially what you're doing here is that here's that receptor, here's that PGY receptor, or P2Y receptor, which basically binds to these damaged endothelial cells. And essentially when you inhibit that receptor, you stop the aggregation of platelets. And so maybe one or two platelets might actually bind to that activated endothelium, but when this drug is on board, other platelets cannot bind to the primary one, and so you dramatically reduce the size and the incidence of clots that can form within an endothelial, a damaged endothelium. Why do we worry about a damaged endothelium? I said the heart attack already occurred. Well, after the heart attack occurred, they physically sucked the clot out, right? And that actually leaves a damaged endothelium behind. In some cases, they'll put a stent, a coronary stent, there to maintain that vessel in an open format. That stent is metal. Often it's drug coated with an immunosuppressant drug, which we'll talk about much later in the curriculum. But that process of removing the clot and inserting a metal stent actually will reactivate the endothelium. And so now that patient is hemodynamically unstable and must be on an aspirin and one of these drugs because of the damaged endothelium, because the worst thing that could be would be another heart attack 3 months from now in that damaged endothelial spot, which is, again, in the coronary artery circulation. So taclopidine has gradually been replaced by Plavix or clopidogrel. And these are the more kind of adverse effects, which really aren't that bad. The most serious is neutropenia, so they'll get some baseline neutrophil measurements and white blood cell measurements, and then maybe 3 months and then 6 months after these drugs have been initiated, they'll follow up and see if the white blood cells and the neutrophils have been altered in any way. Most of the time it's usually okay, and in some cases it's not, then we take them off that drug. So Plavix has kind of like been the major player for several years, but has also been kind of replaced by the newer and much more expensive Efient, which is a prasugrel. Efient is the newest member in this class. What they like about this clinically is that the onset of action is actually more rapid than either of the two drugs before, and so this is kind of better clinical indications. The other thing that we've noticed is that it's more predictable in terms of its ability to inhibit this platelet aggregation process. And the other thing that I forgot to mention in the other class is that there's polymorphisms that exist within that one receptor. This is a better alternative if those patients have been identified as to have some of those polymorphisms. And so now, prasugrel or Efient has been kind of replacing Plavix. And so what does this mean? If the patient has good insurance, you can give them Efient, and if the patient has a PPO or something, they might still prefer Plavix. Each of them has their advantages and disadvantages. They're still good drugs. Okay, I'm not saying that Efient is so much more superior than Plavix that you shouldn't even consider it. I was on Plavix, and then my insurance got better, and then when I came somewhere else, the insurance changed, and now I'm back on the other one, Plavix. So it's fine. They work essentially the same in terms of their clinical outcomes. Right? And so another mechanistic approach would be to inhibit the glycoprotein 2B3A receptor complex. And this complex, when it's working, allows these platelets to cross-link each other and interact with fibrinogen, and that kind of builds the clot. And so in the earlier phase of this mini lecture on the anticoagulants, we were talking about preventing platelets from adhering to each other. Now, even if they do adhere to each other, now we've got a drug or group of drugs to kind of reduce the formation of the clot that exists between the platelets, and that clot's kind of driven by fibrinogen, and that fibrinogen deposition is really driven by glycoprotein 2B3A receptor complexes. And the drug of choice would be this monoclonal antibody called abisiximab, all right? And so this has been kind of studied in some of these preliminary percutaneous coronary intervention trials, PCI trials, whether or not we can give a small bolus of this monoclonal antibody at the time where we take out the clot during angioplasty. And so you might see these kind of moving up in terms of their ability to be kind of put into the therapeutic strategy in the urgent care type setting of the angioplasty procedure. All right. And so this is what these glycoprotein 2B receptors look like in terms of their comparisons against each other. You'll probably see a small clinical trial coming out in terms of really aggressive anticoagulation in some of these high-risk type STEMI patients. All right. And so the main goal here has kind of been to, and I don't know if it was evident, to basically increase oxygen supply through some of these drugs or decrease oxygen demand through some of these drugs. And that kind of restores balance. And so the reason that we worry about balance is because of this ischemic event where the balance between demand and supply was shifted. Okay, supply had gone down, demand had gone up, and that really produces more stress on the heart. So we give all these drugs together to basically kind of restore homeostasis so that the heart doesn't feel as stressed because of all these different processes kind of egging it on to kind of have all these different clinical differences. So of course there's some non-pharmacologic interventions. The stents I had already talked about. Some of them can be drug-eluting, and so there'll be immunosuppressant type molecules coated on the stent, and so basically that exists to basically keep the coronary circulation patent and open. If there's an immune response at the site of the localized endothelial cell damage, that'll actually exacerbate another clot to form, and so that's the last thing we want, especially in that particular area. We want to keep that vessel open. So coronary stents are part of the treatment protocol for post-MI. I have a stent, and it has an immunosuppressant molecule. I think it's got tacrolimus on it. And of course, as oxygen demands are not kept, or recurrent myocardial infarcts occur, or heart failure proceeds in spite of all these different drugs being put on the patient, there's of course coronary artery bypass, and so they take usually a vein, but could be another artery from the leg, and then they literally bypass. So they connect it from the aorta, and they bypass the blockaded portion, and that returns normal blood flow and oxygen delivery to that specific area of ischemia. Okay? So just to kind of recap before lunch, what are the drugs that a patient post-MI is on? Beta blocker, right? ACE inhibitor, statin, which one? Depends on how aggressive you need to be with your LDL lowering and HDL raising levels. Aspirin, at least the low dose, but if you want to go for the 160 milligrams, that's not a bad choice either. Okay, and then probably one of those P2Y ADP receptor antagonists like Plavix or Effient. Okay, questions? Pretty clear? There's a lot of material. But at least it's the same, we've really got the same kind of drug classes in different diseases for different reasons, okay? So mechanistically, if I ask you how does a beta blocker work, it still works the way it did back in MOD. But now if I ask you why you're going to use a beta blocker in the STEMI patient, okay, that's a different answer than why you're using a beta blocker in a patient with an arrhythmia, okay? So yeah, you can bring it back to the same fundamental mechanism, okay, but there's a different physiologic or pathophysiologic reason as to how that drug contributes to the normalization of physiology, all right? What are the drugs that you should use for hypertension? Yeah, so you got your diuretics, either your loops or your thiazides, okay? The hypertension, typically you see thiazides maybe a little bit more frequently encountered than the loops. Your ACE inhibitor, right? What's that? I still didn't hear it. And then, yeah, and then the third option would be your calcium channel blocker. Sorry. Okay. And so then if your beta blocker stops working in the myocardial infarct patient or in the patient with hypertension, maybe you might want to consider adding a low-dose calcium channel blocker on board anyway. So, and that's where it starts to get tough for the students, is that, okay, when do we make the switch? And so we'll kind of develop that. Dr. Shaw and I will be here, and we'll talk about some of the clinical presentations, because there will be a word problem. It'll be a clinical vignette, and you have to make the choice. It won't just be, some of the questions will be, pick the ACE inhibitor. But some of the other questions will be like, okay, they're already on an ACE inhibitor. They're already on a beta blocker. What are the other drugs that you could put them on to, maybe with the option of restoring sodium, or restoring potassium, okay, controlling exacerbations and edema, and so, then you can add on those other drugs. And so that's kind of where we'll spend some time too next week, talking about, adding on some of these other, second and third line therapies and when it's appropriate. Okay? All right, guys, I'm done. I'm tired.